I have limited storage facility upstairs, so I can't do the biggie things. You have 4 young mouths at home, right? 3 kids, and you count for 1, so 4. Here I got 1, and Dana.
Right.
All right. So we are enjoying the playoffs, enjoying this time of the year with exciting.
This
hockey
really is
and basketball playoffs, right?
Because the games count.
The games are counting, and not only that, but this is when the fans really get into it.
Football, I think, spoils people for sports because every football game is so important just mathematically as a percentage of the season.
Yeah.
Whereas basketball, baseball, hockey, the regular season, you win some, you lose some. What's the old saying? You're going to win a third of your baseball games. You're going to lose a third of your baseball games. It's a third in the middle that determines
the
your
60
season.
games in the middle.
Right.
You know, so, yeah. Whereas in sports like golf, where, you know, in the majors and tennis in the majors, every match, every shot is important. May make a difference, right? But that's life and everything, including health. What we do at an early age has an impact on our health in later years. People underestimate that because of a variety of reasons, one of which is the fallacy of the Superman gene, that we're invincible, that we are able to sustain any risky behavior for the longest time, you know, violating our TOWs. We can smoke, we can... drink, the ATAOS as much as we want. We can binge drink, nothing happens. Or binge eat, and we're okay. And we can overconsume anything, right?
Well, some young people can do that, right?
For a certain number of years.
Right.
But that genetic machinery at some point isn't exactly helping them anymore. But you're right. Some are more protected. Like, there are a small number of people that can smoke their entire life and they will not get any type of cancer. It's a very small number. People always quote those things. Oh, I know somebody that's...
But it's rare. That's the point.
It's rare, yeah.
So once again, this is the Leverage Podcast. I'm your host, Davio Venturis. I have with me, as always, the preeminent 30-year cardiologist, Dr. Federico Macy, otherwise known here affectionately on the podcast as Dr. Suave.
Yes, but you look more suave than I, especially with that jacket and that tie, or the handkerchief.
Well, I know.
That's pretty cool. It's got a rose on it.
You're appealing to the advertising demographic with that Wicked T-shirt. So,
but did I tell you I got lucky on those tickets? Yeah, I happened to be in New York with my daughter, and she was young at the time, maybe 6 or 7, and we just happened to be right there at the... first cast of Wicked. I think it was the 4th show ever. And I went to the window right at, 5 minutes to curtain time. And I said, just joking, almost not expecting anything. You got any tickets? 4th row. Middle.
Oh my goodness, Milena.
I'll take him.
The princess. She has such a charmed life. That's so incredible.
The original
cast. That's so cool. Before it was the huge thing that it was.
It was unbelievable.
Oh,
it was probably one of the finest shows I've ever seen.
And
I've been to a few.
And it's such an amazing subversion of the Wizard of Oz.
Amazing.
Spoiler alert.
The backstory.
Right. And
of the witches.
I had really hoped when they did the new Star Wars
Yes.
that they were going to do something like that and retroactively try to change. And of course, they just did what they did. But let's get to the topic of today's episode. In a previous podcast, we were talking about the American health care situation.
Yes.
And how we are facing a crisis, a budgetary financial crisis if current trends continue. And I would like to hear because you're literally on the front lines treating people. You've seen the trends of, as you said, the 80s is when it all started to go pear-shaped, literally.
Right.
So I guess my question is, what's going on with the American healthcare system? Where are we headed? And what can we do to fix it? And how does that tie into why we even have this podcast?
Okay. So, huge topic. So we need to break it down into
And
segments.
please try. And Chandler's telling me right now that we need to try to keep this within 30 minutes.
Yes. So how to fix the U.S. healthcare system in 30 minutes or less.
Right.
Beautiful. Okay. Let's see. No one's been able to do that since the Clintons tried, and then Obama tried, and I guess Trump didn't do anything. And so here we are. So here,
Well, but they're trying top-down methods.
They're trying. Yes. So let me go at it in a different way.
Okay. Let's start.
So breaking it down, I'm going to say where we are right now,
Right.
and we're going to talk about three different things. One is the cost burden.
Right.
Then there is the optimal medical delivery of healthcare model. Okay, and then there's the ancillary, all of the businesses that go around it, and including in that medical education.
Right.
Okay, and research and drug development and technology development. All of these are extremely important because they are a critical part of the model.
Okay.
Okay, so let's start with where we are today. So 2022, we spent in the total national healthcare expenditures were a little bit over $4 trillion. Just to put it into perspective, that's about 19% of our gross domestic product.
It's just spent on healthcare.
That's it. Okay, so just to compare, the defense budget was somewhere in the $750 billion for the year. Healthcare, 4.1 to 4.2 trillion. Okay, so that's 5 times more.
It's funny you make that comparison because to me, there's all this debate about, socialized medicine, this and that.
We'll get there.
But to me, healthcare is a defense issue. Hear me out.
Yes.
Heaven forbid there's some kind of big war that happens,
Right.
big or small, what needs to happen. You can only fight with the soldiers that you have, the population that
Right.
you have. And by a quirk of the human species, we're not like horses.
I thought we had Rocket Man.
Or we're not like pigs where you can have a full-grown
No,
warrior.
Iron Man. One guy.
That doesn't work.
Little fantasy, right?
But you can't have a new warrior pop out every 3 months like
Correct.
wild boars can. It takes at least 18 years to train up the next generation.
Right.
So when you have an unhealthy population that isn't, let's face it, people who live a sedentary lifestyle and have hypertension, obesity, diabetes, usually there's occasional obvious exceptions like NFL linemen,
Correct.
right? That are just
going to die younger.
well, that ends up happening as well. But
Yes.
but most people who are in that condition, which is such a large percentage of our population, are not good warriors. So for defense purposes, you want to have a healthy population.
No doubt.
To me, that seems easy.
And right now, where we have been over the last 2 years, especially with COVID, is that the longevity of the younger people is less by a year or two than their parents. So we're going in the wrong direction. So let's get back to the financial thing because we can go into tangents like that. Okay, so now,
that isn't the tangent. That's
this
the
is
question.
the cost. So the U.S. is one of the countries in the OECD, the Organization for of Countries of Economic Development, that have a similar socioeconomic status.
Developed countries.
Yeah. So we are the most expensive by far in terms of healthcare costs. The average per person.
But we have the best outcomes.
No.
So we're the most expensive and don't have the best outcomes.
Yeah, we're in some things we have great outcomes, such as in oncology. In cardiology, we're about number 3, 4. But we're like 16 overall. We don't have the best outcomes.
For health outcomes.
So correct. Overall health outcomes, longevity, et cetera. We're at the bottom of the developed countries, the so-called developed nations, okay? Yet we spend a lot more than anyone else by far. Even a country like Switzerland, which is the second highest in expenditures, who as a country has 7 years average 7 years older, they spend a lot less, like a third less. So our average cost right now is probably around $13,000 to $13,500 per person. You cost $13,500 per year. I cost $13,500, and so on and so on.
Right.
Right, for the total budget of $4.2 trillion. Approximately half of it is paid by the public sector, and the other half by the private sector. When I mean public, I mean Social Security, Medicare.
The socialized medicine
VA.
that America already has.
We already have a socialized medical system that treats somewhere around 155 million people currently,
Right.
because there are close to approximately 70 million people, close to 70, 72 million on Medicare, and then another, 75 to 80 million in that range. I don't have the latest numbers, but it's around there on Medicaid. So it's a little over 150 million on these two programs. And remember, those programs were started in the mid to late 60s because of the New Deal with LBJ, right? So, and then we add the military, which is another 18 to 20 million. So it's a large number that is already on socialized medical. What is the cost?
Don't we have more people in socialized medicine than almost every European country?
Yes, correct, by far. Germany has 60 million people, France 40 plus million,
Right.
and so on, right?
And we have more people on the
Yes.
Yeah.
Okay. If you combine Italy, France, Germany, Spain, that's what we have. Okay. All those countries. So we already have a model. And the point is this: Medicare by itself is the most expensive. It costs over $15,000 per person.
Right.
Medicaid is closer to about $10,500. Those in the private sector, that means they're insured through their employment or self-insured,
Right.
as I am. I pay my own. The cost is about $9,000 to $9,500. So there's a
Why
big
is
difference.
the private cheaper?
I think it's because most people in private Medicare are people with professional employment. If you look at per person, the average educational level is higher. And we know that the social determinants of health have much to do with educational level.
It's better diet and access to better activities.
Yes, and more awareness,
Got it.
about
That's why they cost
proper
less.
behavior.
Got it.
Yeah, so you have less expensive surgeries, right? So right now, Medicare in 2023, this year, pretty close, we're going to get to an expense of approximately by 2027. Let me project a little further out so we know where we're going, because the cost of medicine increases by 5% per year. So according to CMS, that's the Centers for Medicare and Medicaid Services, has a department that looks at the costs over the next decade. So last year we were at 4.1 to 4.2 trillion. By 2027, the cost will be about 5.9 trillion. By 2030, 6.9 trillion. Okay? So for Medicaid,
Is it going to come down once the boomers start dying off?
No.
Is part of this increase because of the boomers?
No.
What's driving
In
this
part.
increase?
yeah, well, we have just an unhealthier population. But let me just go for the number so you understand. Right now, what we're collecting in income tax is barely 4 trillion. Barely 4 trillion. The cost, national healthcare expenditures are at 4.1 to 4.2.
So we're already running a deficit just to do it today.
Just that. That means there's no money for anything else.
Right.
Okay? If you really want to,
unless we're borrowing.
if you want to balance the budget, unless you borrow, you're in a deficit just with medicine. In addition, by 2027, the cost will go to 5.8, 5.9 trillion. By 2030, 6.9 trillion. Okay? So by 2027 or so, the cost per Medicare recipient will be $19,900. And there will be over 72.5 million people on Medicare by 2027. Okay? Because every day, somewhere between 5 and 10,000 new individuals become 65 or over, so they join Medicare.
Right.
Okay, because Medicare is, for those of you listening to us who aren't aware of this, Medicare is for 3 kinds of people: people who with disabilities, people on hemodialysis, and people 65 years of age.
Did you say
and older.
hemodialysis?
Hemo. Getting their they have end-stage renal disease and they're getting dialyzed. Medicaid are for people that are of the socioeconomic level at the disadvantage there. And there is a line called the national poverty line. And if you're less than 138% above the national poverty line, you qualify for Medicaid.
Okay.
So basically, the amount that by 2027 the healthcare system is going to cost is over
way more than what we're taking in now.
Yeah, $2.5 trillion.
Basically, there's a time bomb.
Just in that.
So there's a time bomb coming.
Yeah. So the politicians saying Medicare for all, just on those numbers, doesn't work. And in order to really, if you were to formulate a medical model for the U.S., for any country, you have to think of three main factors: affordability, quality, and who do you cover? Do you do
coverage?
Universal coverage or not?
Right.
Universal meaning you cover everybody or not. It's easy to say in a socialized medical model, let's just cover everybody and give everybody the top quality, but then your affordability goes down the toilet. You can't afford it. So what happens in places like England, Canada...
But hold on, before you say that, your affordability, let me push back a little bit, because with preventative strategies, can't you make the affordability much better?
Presumably so.
If you have a healthier population that's doing healthy behaviors, I mean, isn't that one of the whole ideas behind the Leverage podcast, is to try to do something to plug the hole in this tidal wave, which is going to overwhelm our budget.
You're absolutely correct. In an ideal world, spending your money on prevention is what we should do. But thus far, preventive strategies have proven to be extremely expensive and ineffective at curbing events.
Okay, dig into that a little bit more. Why have preventative strategies not been a phase? Is it because the people, you can lead a horse to water and they just won't drink?
Well, you have to break it down in context. So in cancer, for example, you're talking about female health, okay? When we do cancer screening with mammograms, that saves lives.
Right.
That works.
Right.
Okay. So there's specific examples where we've had tremendous success, and the U.S. is at the forefront of this.
Right.
Okay. When you do certain genetic testing in women, for example, with BRCA1, BRCA2 genes for cancer, especially when they have a family history, that works.
Okay.
It's very effective. It has been a tremendous success.
Okay.
Okay. In doing screening colonoscopies for especially 50 and above, to detect, polyps that may become malignant.
That means I'm due.
Correct. So that means that's successful as well. In certain populations at risk, checking prostate, PSA, it's a blood test for prostate cancer, has been successful. Okay, but there are very few strategies for prevention that focus on the elephant in the room, which is diet and exercise. That is where we have our greatest death, as I mentioned on a prior podcast, where our number one cause of death is cardiovascular disease.
Right.
And that's related to genetics, but more importantly,
nutrition and
movement, right? And TAOs.
I don't know if you saw my most recent Instagram post, but it was inspired by our conversation. I said you need imagination and movement.
And movement, absolutely. So, and then cancer with, again, genetic predisposition and exposure to various environmental agents, et cetera, and tobacco abuse.
So they haven't been able to get people to do the nutrition, and is that the problem? Or
correct. And we've had brief successes with the smoking, but now smoking is on the upsurge. But since the 1980s, because of a prior podcast that everyone I would encourage to go listen to, on what happened with respect to sugar.
Right.
And
I think that's our third episode.
Yeah, exonerating sugar, and the seminal papers put forth by the FDA, the National Academy of Sciences, the Attorney General, American Diabetic Association.
So now that we know this about sugar, can't they turn this around? Can't we change these numbers?
So this is where we come to the model.
Okay.
So clearly, the expenses keep going up by 5% per year.
Right.
It's going to be unaffordable.
Unsustainable.
And if you put everyone on Medicare, you don't have enough dollars in the tax revenue to pay for it. You just can't.
Right.
It's impossible. And if you say you want to maintain quality where everyone has access to transplant, to the latest prosthesis, to the greatest imaging technology beyond MRIs and PET scans and three-dimensional ultrasounds, and where you have the greatest, most affordable brand name drugs that you can pay for, part of the system that are included, you can't afford it.
Right.
Okay. As the population continues to grow, we estimate by halfway through the century, by 2150. We're in 2150.
Yeah.
Yeah, we're already in 2150.
No, we will be there. Right now we're 2023, but 2150 is
so 2050. We're going to be arguably close to 350 million people, right?
right.
And so we have an affordability problem here. And we have right now an increase on teenage obesity, child obesity, and this fosters a bad situation because we're going to have more prediabetes and diabetes and eventual cardiovascular disease.
Right.
Which is Leverage podcast is about saying, hey, let's all become accountable so we don't have this crisis, as you mentioned earlier, down the line. Right. So we want to promote the preventive strategy that starts with you, with the individual. What you can do today, don't let it go on, and go walk or exercise, eat better, right? Let's become educated about nutrition. So schools have gone away from teaching nutrition. Schools have gone away from extracurricular activities, after school programs, like a country like Norway where everybody gets to participate for free in expensive sports, I might add, like skiing and ice hockey and those winter sports are very expensive, yet everybody gets to participate whether they have money or not.
Right.
And get free equipment as part of the mandate from the country.
The American model where kids are filtered out at a very young age, I think is awful because you think of some of the greatest players of all time in different sports who weren't great when they were young. Now, obviously, most big stars are stars
they
from
had
the moment.
Genetics, they had amazing
but not always
advantages. No,
sometimes
they worked at it.
Yeah, sometimes players can have skills that aren't the norm for their position, but it ends up being a new tactic or a new strategy. And
they weren't indoors playing video games, eating bad foods, and not playing with their friends. It was the opposite. We know all that, and our listening audience knows all this. So let's stick to the healthcare system. So in order to deliver a better model, I presented a model not long ago in what I call a white paper. It's not that long, only 50 pages. That I called the blended plan, a Medicare optional model or Medicare opt-in model. It's your choice. And I estimated that about 200 million people would immediately opt into it.
Okay.
So it involves Part A and Part B, as the name implies, the blended plan. So it blends Part A, Part B. What is Part A is the medical home. So the medical home would be a primary care clinic that's open 7 days a week, 12 hours a day, staffed by a medical doctor, primary care provider. That can be a family practitioner, internal medicine doctor, with some nurse practitioners or physician assistants. And it has a staff that's composed of a social worker, of an exercise physiotherapist, a nutritionist, obviously the medical providers, and transportation.
By medical providers, you mean nurses?
No. The MD and the nurse practitioner.
Right.
Or physician assistants. These are called the medical providers.
Right,
You don't need a nurse
Okay.
in the outpatient primary care.
Right.
Nurses are amazing RNs for hospital, urgent cares, emergency
Surgeries.
departments.
Yeah.
They're at a much higher level in terms of their ability. For the outpatient medical clinic, when I say nurse practitioner, I mean...
This is the medical home for people to have.
Yeah, medical home. You sign up for it online, and it's paid by a membership. And if you don't have the money to pay, that's where the government... local, state, federal,
subsidizes people.
Yeah, and the one I started I used to charge $30 a month, and their visits were.
Why is this model better than the hospital model
I'm going
we
there
have now?
Because there's a double accountability program in my model. One is on the patient that has to learn about their disease complex. So if I diagnose someone with diabetes, then they got to we provide information, educational curriculum, and 4 times a year, they go for a 1 to 2 hour class at the local high school to learn about diabetes and the complications.
Right.
Okay. So, and then that participation in that gives them the coverage for the next year.
Oh, wow.
Yeah. And so on and so forth. And the doctor is often the speaker, or there's a rotation. So there's a curriculum, and you're going to go talk about what insulin resistance is, for example, or hypertension, or cholesterol, or sleep apnea and obesity and so on. And on top of that, so the doctor is being graded on what I call the health physician score or provider score, which is out of 5. So how well do you control your diabetics, your hypertensives, your patients with cholesterol issues, with respiratory issues, and mental health and substance abuse
So
issues?
the feedback is on how well they're handling their population, basically.
Correct. Well, it's not a feedback. There's going to be an auditor that's going to do
That's
audits
feedback. That's feedback.
to the and score out of 100.
Right.
And so the doctor, let's say the new model, let's call it the new Medicare.
So you're trying to change the incentive structure, basically.
Well, no, you hold them accountable.
That's
to
what I'm
keep
saying.
People healthy, right? Because the doctor's salary goes up as they are better controlling those risks, those 5 categories I mentioned.
Right.
Remember, and just in case you didn't hear the last one was mental health and substance abuse issues. You have to address that on your visits, okay? And that includes cigarettes and alcohol and others, right? So in the clinic, you have the supporting infrastructure. You have a nutritionist, exercise physiotherapist, a social worker, and a transportation manager. And these people can engage with your patient at the provider's direction to say, hey, this lady doesn't have a lift. She lives in an area that has a scarcity of good food availability, what are called food deserts. So she's got food stamps that the social worker helped with. So take her shopping here at this day, this week, and bring her to her appointment.
So it looks like you're spending more money on each individual person, but what you're saying is that the increase in health outcomes will pay for itself.
Correct.
With this kind of model.
Yes. So the model will have an open door policy concept, and it's already been tried and it's been proven to be successful.
Well, we know that if you don't treat people preventatively, then they become more expensive.
So IORA, I-O-R-A, is a model started by a very smart doctor that I don't know personally, but I think he graduated from family practice.
What is the
at
IORA?
Harvard. It's the name of a bird that sings beautifully.
Okay, but what's the model?
The model is what I just told you. A medical home that gets to know the patients very well. They get a certain number of assigned patients, and a membership is paid per patient. So right now, I told you at the beginning that per Medicare patient, we're spending over $15,000 a year.
Right. Well, that's coming, yeah.
So even if you pay per patient $1,800 a year, $150, unlimited visits, a patient never pays. Let's say the federal government sponsors 2,000 Medicare beneficiaries to a medical home.
Right.
2,000.
Right.
So the medical home is obligated to be open 7 days a week, 12 hours a day,
Right.
well-staffed with receptionists, medical assistants, people on the phones, and the providers, plus the adjunct professionals I mentioned.
Right.
So Mrs. Jones, who's 68, comes in, and she's got 8 main problems. They're all addressed. She can come into that medical home anytime, even without an appointment. You have by appointment, and you have the walk-in line. And you have enough providers to take care of both at each visit. And $2,000 at $150 each per month is $3.6 million a year on 2,000 patients. I don't want to do the math for you. I've already done it.
Yeah. So, but
The overhead will be $1.5 million to $2 million. You run the most amazing center, and you're going to decrease, I anticipate, by 10 to 30% the number of ER visits and hospitalizations, because you're going to control the 5 parameters more efficiently.
so why is this better than the hospital model we have now?
Well, just do the numbers. Right now, it costs $15,500 per Medicare beneficiary.
How are you
And
able
it's
to do
going
it so
to
much cheaper?
$19,000. I'm going there because I can see Mrs. Jones 8 times in a month to control her blood pressure for any little UTI, any complaint. Before you go to the ER, I'll send our transportation manager to pick you up and bring you here. And then I'll let you know if you really need to go to the ER, because 30, 40% of ER visits are unnecessary and they cost a tremendous amount. And in for-profit hospitals, there's an incentive to keep them to charge.
That's the thing.
It's a huge, and then the
So we
racket-
got to change the incentive. That's the problem.
Yeah, and so you have
And the lobbyists don't want the incentives to be changed, so which is why none of this
remember
happens.
the lobby force in medicine, the lobby dollars, is over $750 million a year, over $700 million a year.
That's like 5 times more than
Defense lobbying, right?
Yeah, wow.
So
That's a
the
powerful.
the medical home is accountable to an auditor that will see where that physician group ranks locally and nationally, depending on the risk level of their patients.
And so the doctors get
a
compensated
raise, an extra $5. You started at 150, you go to 155.
We don't have to do specific numbers because inflation's going to change everything.
But then that doctor, the government says, hey, you, Dr. Smith, you're doing amazing. You have the lowest unnecessary ER visits, the lowest need for surgery. Because if I control three things, okay, diabetes, cholesterol, blood pressure, and keep people from smoking, I'm going to dramatically decrease within 1 to 2 years the number of heart attacks, strokes, congestive heart failure,
and diabetes medication, all that stuff. Right?
Yeah, in my population.
So the secret to wrap it all up into a bow, you have a model, obviously,
yes.
and there's other models out there that
the blended plan.
Well, and other countries have models that do well as well.
And I've studied most of them. So I put together a hybrid of what works, and I know that the more contact I have with somebody as a cardiologist, the more likely I'm going to get them controlled.
Right.
Because 80% of the dollars in the U.S. are spent on chronic diseases. So our goal is to prevent chronic diseases in young people through nutrition, education, starting with allowing people like myself to run nutrition and education and exercise education programs in the public school systems. There are plenty of doctors who are retired who would gladly do it.
Which was one of the ideas for your book series. Now,
Correct.
Now we plug the book series, the children's books for children's nutrition. Do you want to go ahead and plug it?
And yes, absolutely. The Eisenhower series, Fred Macy, Amazon. And then on top of that, you have accountability on both sides for the patient to continue to get sponsorship. And it's income related. So let's say for a 50-year-old who wants to opt in, remember, Medicare starts at 65 and above, or in the disabled population, or those on end-stage renal disease. You got a 50-year. Let's say you say, private insurance are quoting me $800. If I opt in, what will it cost me? So you'll pay a little more than the 65-year-old and above, because presumably you worked fewer years, you've contributed less in tax revenue. So you may end up paying about $300, and you'll have a deductible of $1,500, but your visits won't cost, and you'll belong to a medical home. And the goal is...
Wait, so if you're in private insurance, you're not in a medical home? Is that the
No,
plan?
you can, but you abide by the standard, model right now. But you may say...
So let's put the model to the side because we got to wrap this one up. So the whole point about the model is to keep people accountable, right?
And healthy in an outpatient
Right. But the way it works, what makes it better to what is superior to what we're doing now is that it's trying to keep people accountable because...
Yes.
At the end of the day, is what you're saying, to answer my question let me see if I can summarize it in layman's terms.
Yeah.
The problem with our healthcare system is, there's corruption. Yeah, it's not ideal.
30% is wasted. But
the main problem is just the health of the people themselves. And
yes.
until we get a handle on that,
exactly,
it's all going to fall apart.
We're in a losing trajectory. And don't forget, I do want to say, the second part of the model, because I said it's a blended plan. I have to, because
everybody has to drink.
Because someone is,
I know,
listen,
but
someone
we're
is
already
gonna,
at 33 minutes, Fred.
Someone is going to text us and go, what if I break my leg and end up in the ER?
Right.
Okay, the medical home can't do surgery, right? So then that's where you get a contest, either by state or by region or national, on the government purchasing large insurance packages for the 5 different risk populations in the country. So everyone in this model will have a medical home membership and a purchased commercial insurance policy.
For catastrophic.
Yes.
Yeah.
Right. With a deductible less than $1,500. So everyone...
Well, there's two sides to the medical, right? There's the trauma, catastrophic, could happen to anybody at any time.
Correct. Cancer.
No, there's no prevention for that besides don't leave your home.
Yeah.
And even then, your home could fall on.
Correct.
So
anything can happen.
That's separate.
Yeah.
What you're trying to, and that's going to exist no matter what. But what you're saying is that what we can take in control of, the individual accountability to make better outcomes.
It's teamwork, yes. But you need to have the part B, which is the hospital specialist ER coverage.
Right.
And that, instead of the government being involved in that, they purchase the products from existing insurance companies like they do in Switzerland.
Right.
Switzerland, 99% of the population is covered with commercial insurance.
Right.
But there are 100 plus commercial insurance companies bidding for your business. And so you can go purchase from the one you want. In Switzerland, the employer provides a certain amount per person in their paycheck to go purchase their own commercial insurance. Okay? And that employer gets a tax deduction for giving you that money. And you can buy, the government sets the minimal bar of benefits.
But this is separate from the home now?
Yes, it's part A, part B. Let me start again. Part A is a medical home.
We don't have time to start again.
It doesn't matter. This is important. I don't want someone texting, what if I break my leg? The medical home can take care of me. Correct.
Well, yeah, you have the part B.
Part B is commercial insurance that is purchased
But what about the people that
in
can't
bulk.
afford?
Then they get, exactly. So those are the ones that get sponsorships for their commercial insurance. So you may end up having Blue
the
Cross.
government.
Correct. You may have Blue Cross, but
And that's how they do it in Switzerland.
correct. And
Okay.
so if I have, and in other countries, and if I have, if I'm buying 10 million policies for my age group 50 to 59, I'm going to do a bid with Aetna, Cigna, Humana, Blue Cross, and United Healthcare, the big five big
Right.
ones. I'm going to purchase today. I'm going to sign a check. Let's start the bidding. And the United guy says, well, it's going to be $750 a month per. And the other guy, well, I'll give it to you for $725.
And then they'll all wink and keep the price high.
You set the minimal benefits that it should have. And then you go by income of the individual, who gets sponsored, who gets to pay a little bit. So let's say you make less than $50,000 a year. You may end up getting
the numbers.
right. It's a sponsorship table
The
that
numbers
allows
are
you
the actual numbers are irrelevant because with inflation, when somebody listens to this in 2 years, who knows what 50,000 even means? That might be the price of popcorn.
But my point is there's a sponsorship level of income. So if you make above a certain number, then you pay for it.
Right.
You can opt in and pay for it, which still be less than buying the policy by itself because that commercial insurance policy is only covering ER visits, hospitalizations and surgeries, and specialty consults. It is not covering the medical home. The medical home is on the membership that I mentioned before for the Medicare's $150, people under that $125 a month. Right?
Or whatever the number is.
And by the way,
when time comes.
that includes your labs. That includes all of that because the cost of labs is very inexpensive. So now you have adjunct.
And it's better to have people have more labs more often.
If they have the risk factors for cardiovascular disease and cancer and so on, absolutely. So you can control them because the budget goes through the roof with people with chronic diseases that are uncontrolled. And we have a very poor record in the U.S. of controlling blood pressure, diabetes, and cholesterol. Very poor.
Even though we're on the wrong trajectory, I'm optimistic that with technology improvements, plus the more awareness, people listening to podcasts, I think that we might be able to turn this around.
We'll move the needle in the right direction. But we got to slow this train. And right now, from what I hear in Washington, I'm not well in tune with it, but what little I hear is that no one is doing anything about this. Like that no one is proposing a model. So the blended plan.
Right now, no.
No, I have the blended plan. It describes all of this, and then relationships with pharmaceutical companies, relationships between the medical home and the hospital systems, and the medical education.
Fred, I think you should put the
all of that.
I think you should put the plan up for people who are interested in going more in depth.
We need to get our producer to put it up so it's a click away. I'd be happy to do that.
Okay. Well, thanks once again.
There are 2 typos in it, so I'm sorry.
That's all right. Well, maybe get those fixed first. So this is thank you once again. This has been the Leverage Podcast. I'm your host, Davio. This has been Dr. Suave Federico Macy. And please like and subscribe on YouTube, TikTok, Instagram.
We can save 30% on the blended plan right away.
I'm sure.
Maybe more.
TikTok, Instagram. What's the other ones? YouTube. Oh, rate us on Spotify.
Yes.
Am I forgetting one?
Facebook. Yeah.
Instagram.
Well, we get some segments on Facebook.
Instagram. That's the one.
Yes.
And we'll talk to you guys soon. Great to be here. All right.
Thanks
Thanks
for the blended plan. And here we are.